Welcome to the DKA channel. I'm your host, Nurse David, and thank you for joining us. In today's episode, we are going to discuss the role of a case manager in the hospital setting. And to help me discuss that is our wonderful guest here who has been a long-time nurse and currently practicing as a case manager, Saba. And so, hi, Saba, and welcome to the DKA show. And can you please tell us a little bit more about yourself?
Yes. Thank you, David, for having me join you today on this episode. My name is Saba, and I have been a registered nurse for more than 20 years. And I have practiced in different settings, mostly in the hospital setting. And I've been practicing in the Seattle area in Washington State. I've done different kind of nursing. I have been a charge nurse, float pool, you name it. I've done a lot of it. And about 4 years ago is when I started to be a case manager, still in a hospital setting.
Oh, nice. And so how long did you practice actually at the bedside before transitioning into your current role?
It has been at least 22, 23 years. I practice bedside nursing. And I left bedside nursing in 2021 after the COVID. Well, COVID was going on. And that's when I went and became a case manager. So it's been about 4 years now.
Nice. So what does it take, as practicing case manager, what does it take to become one?
Okay, that's an excellent question. And for me, having practiced nursing, different type of nursing has really helped. There is really no formal training to be a case manager. So it's on-the-job training. So when I went to become a case manager, I did have a 6 weeks training, hands-on, taking patient, had preceptors. There is a lot of education, material you study, regulation, stuff like that. So the didactics and then the practice. So altogether about 6 weeks, hands-on.
6 weeks hands-on.
Yes.
Wow. I didn't know that, right? I thought maybe there is a special training that you have to go do, like maybe this certification for med-surg or ICU and stuff like that. I thought maybe there was a certification like that for case management. But
there is a...
There is?
Yes, there is a certification for case management through the American Association of Case Management, the ACMA. The requirement is for you to, if you have a bachelor degree, they do want you to have at least a 2 year of practice. And if you do have a master's, it's about 1 year, and you can sit for the exam. So
is it like 1 year, 2 years of practice as a case manager before taking the...
Exactly.
Oh, okay. So you don't have to take the exam before becoming a case manager?
No, you don't.
Oh, okay.
You actually have to have worked in that position, and your direct supervisor does have to attest that you have been. So if you do have a master's 1 year, you can sit for the exam.
Oh, nice.
Yes.
Oh. And so, let me ask this. So, how in the in the nursing world you'd have, like, let's say, some specialties, right? Like somebody doing L&D and somebody doing like acute care, somebody in an ED. In the case manager world, do you guys have anything like that where like are there differences in the kind of things you do as a case manager? Like, are there any different types of case managers?
What I do now is inpatient case management, but there's outpatient case management.
Oh.
So like, let's say, home health agencies would have case managers. It's outpatient. There is some insurance entities who do employ a case manager, and usually it's like preventing readmission, disease management, and following up with the patient, and for better outcome.
Oh, nice.
So those are the ones. Social workers can do that as well.
Yeah, and that brings me into asking you this question, where the difference between let's say the RN case manager and somebody who is like trained as a social worker, is there like any like difference in the kind of work you guys do, and how does it look like?
So the roles are pretty aligned, but also different. For like social workers, they do the psychosocial assessment on patient. They do a lot of behavioral health assessment, substance use disorder, like a whole, and the drugs. So they do a lot of that, and they mainly do like adoptions for newborns. So they cover like the special care nurseries, the maternity ward. So that's one of the roles they do. They have a lot more knowledge of the community resources, I feel like. So social workers are very valuable. I know some hospitals, they do have a social worker and an RN on a case, on a patient, because the social worker can handle the psychosocial, like the housing, disability paperwork, stuff like that, where the RN is more clinical.
Gotcha.
So we mainly work like, for, let's say, setting up home health, home infusion, discharges to like ambulatory centers, stuff like that. So there is a little bit of difference, but at the place where I'm working right now, we basically do almost the same assignment, same kind of work.
Yeah.
But like I said, if it's like psychosocial assessment, counseling, the social workers would come in, so we would ask for them to get on the case.
Yeah, which is very interesting, because I didn't really know the clear differences between the work that the social worker does and the case manager does.
Yeah.
So you coming here and talking about this is very helpful.
Yeah.
It really clarified that in my head, and I can really see the difference in the roles now, which I think most of our viewers who don't also have enough experience or know the difference would, through this conversation, would get to know
Yes.
the exact role of the case manager and the social worker. So like you said, if I understand you right, the social worker focuses on the psychosocial issues, and whilst the case manager focuses more on the clinical issues, right? So let's say I have a patient who is sick and was in acute care and is getting ready to go home. If the patient is going to go home, the social worker is more looking into the environment they're going to live in. Case manager might look a little bit into that, but if they will need, say, a rehab before going home, social worker can coordinate the rehab, but do you make the determination on whether they would need this kind of rehab, or is it the doctors that make the determination?
That is an excellent question. So, like I said, the roles seem a little different, but we work collaboration.
Yeah.
So, let's say a social worker can do the same work I do, which is care coordination, post inpatient stay. Like you mentioned, if a patient needs to go to rehab, the social worker does that as well.
Oh, okay.
I do as well.
Yeah.
So they will have their assignment, and I'll have my assignment. I will work on my discharge planning, care coordination, and the social worker will do the same. But eventually the model is going to be a social worker and a nurse on a case.
Oh, okay.
There may be some clinical needs and also some psychosocial and more resources out in the community. So that is what we're doing right now. But I understand there are some hospitals who do have that method of social work and case manager on a case. They can do the initial assessment when a patient comes in as much as I can do it. So we do have the same workflow.
Okay.
And like I said, the only difference you see is like they are mother baby, special care nursery, adoption, surrogate, stuff like that. They deal more with that one.
Oh, okay.
Nursing is not assigned to that
kind of case
per se, but going to a rehab or assisted living or home health, the social workers also do it as well.
So there is some kind of overlapping
Yes.
practice in most of the
Yeah.
circumstances, but also there is some differences in.
There is some differences
Okay.
in the disciplines.
In the disciplines.
Yes.
Okay. That's interesting to know, right? I didn't know this, right?
Yeah.
And so so that's, you say, pretty much the difference between the case manager and the social worker. So if somebody wants to become a case manager, with your experience, you were on the bedside for a while before you transitioned into case
Yes.
management. If somebody wants to become a case manager, what do you think would be the best way to go about it?
The best way to go about it would be have some strong clinical understanding. I think for me to have a successful transition, being a charge nurse was critical for me. As a charge nurse, I always look, about the patient, where they're going, what do I think the discharge plan would be. I always had that hat on. So coming here, it was an easier transition for me. So I would say having at least charge nurse position, understanding that, participating in like discharge rounds, and understanding what community resources are out there is essential, and also, good clinical assessment skill.
I mean, that's very nice to know that, the charge nurse position was very helpful in terms of sort of giving you a good foundation into the transitioning into this role. So if you are watching and you want to be a case manager, try being a charge nurse. It might help you, along the way to make the transition very easy for you. So looking back at everything that you've done, what would you say is the most challenging part for you in your practice?
I would say the most challenging part would be some resources that are lacking in the community, such as housing. Getting a patient into a permanent housing, there is a long wait. I'm saying like people who are unhoused and need a stable housing, or whether it's a transitional housing, a shelter bed, safe discharges. So those are resources that are lacking. Finding patients who don't have primary care, getting them connected to primary care so they can manage outside the hospital system, and decreasing readmission and visit to the emergency department. So that's one thing. The other one is uninsured patients. We have waits for like a dialysis chair, patient going to dialysis. We do have some challenges with insurances that are not accepting by a lot of like rehab places. Resources like that. Transportation is another one. There is a lot of items that make a patient successful and healthy. The social determinant of health, like transportation, food, finding grocery.
Good housing.
Stable housing, transportation. Can they get to their doctors, to their follow-ups? Are they able to get there? What type of transportation? So we have that lacking. Finances, like affording medication for patients. Some medications on discharge are quite expensive. Are they able to afford the copay? So that the challenges I see, and
And I think I have been as a practicing nurse. That's something I think about. Like sometimes the ethical challenge between like what the system is providing and what the institution is also asking or requiring from you, right? For instance, like you're saying, somebody who doesn't have insurance or coverage for certain things, right? But they also don't meet criteria to receive assistance, and so you have to let them go. And for sure that where they are discharging to is not the best condition.
Yes. No.
But sometimes the hospitals like, we can't keep you we have to let you go.
Yeah.
But the patient also said, maybe whatever options you have for me is not the best for me.
Yes.
And I don't want to go there.
Yeah.
So in that situations, like you as a person, how do you feel it impacts you? And also what do you think could be done differently, in that sense?
Family support is very critical. Who's able, willing, and available to help. That is an issue. And like I said, the unhoused patient would have a difficult time, especially in the cold weather, the snow time. We do have some cold weather shelters and stuff like that. They may not be able to get there on time. It's a balance. When a patient is medically ready to discharge the hospital, we want to make sure they are discharging, because we do have other patients who are waiting for the bed, and our emergency room is always busy, and we have a lot of boarders. But then again, on the other hand, is there a stable place for this patient to go? So to help with that, so we do start the discharge planning on admission. We try to see almost every patient within 24, 48 hours. That's when we identify what is the goal of the patient. Does it align with their post-hospital discharge needs? So we do that. So we identify those patients who have discharge barriers, and we have a list where we put the patient on a discharge barrier, and we say, what can we do for this? So we start planning early, and what type of resources the patient have. We build on their strengths. What can we do? So we explore a lot of things like that. Then we also have partners who help us with the placement. So we involve them. If a patient needs like a permanent place to go, like into assisted living, or if they need to go to an adult family home, we have partners we can involve with the patient consent, and they will do it for free. There's no cost to the hospital. So they will come in early enough, and we assess, and they will bring a registered nurse to assess the patient and see what type of post-hospital discharge is appropriate. And it involves finances. If the patient is have the resources, usually it's a private pay, and that's arranged. If the patient qualify for assistance from the state, we do screen them for Medicaid. And we initiate that early on, and we work with the financial department of the hospital, and we identify patients needing long-term care services. So our financial advisors, they will screen, and they will work with the patient, and they will apply for Medicaid long-term care. So after that, we involve the state, and the state will come and do some assessment for us, and usually they'll give you like a daily rate, how much this person is going to have.
Okay. And would that be more related to maybe their care post-discharge?
Yes.
On how much and so would that also lead to determining, let's say, if they need if they need outside care, right? Says they want to go home with home health or something. Would that determine the amount of help they're going to get from, after their discharge? Because let's say if the state say we are only going to pay you this amount of money, and because that is what we think you need, and then maybe the patients go out there and they feel like they need more care. Let's say even if they're having somebody coming in to care for them, right? And if they feel they cannot, if they feel the amount they are receiving cannot support or fully pay for it, are they expected to pay out of their pocket in terms of the balance, or do you think that they have to come back to you guys to see if you can negotiate some increase for?
Yeah, that's a good clarifying question. So when we have a patient who is going to be on long-term care Medicaid, meaning like, are they going home with caregivers? That's an option. The other one, are they going to be in a placement situation, like into adult family home? Mostly that's what we use. Some assisted living. So they will assess the patient and see how many hours, like when they go home, a month, how many hours they're going to get. So that will be determined by the home and community service assessment. Usually it's a social worker who will come in a complete assessment. if they go to an adult family home, so at that point, the patient leaving the hospital into the community, they'll have an assigned case worker from the state. So if they feel if the patient or family feels like it's not enough hours, they can be reassessed. Other than that, is yearly the state assess the need.
Oh, okay.
And if they go to the adult family home, they say they have a rate of 150 a day, and the adult family home will agree. But if there's a change of condition once they're out in the community in the adult family home, they can be reassessed and
okay.
Yeah.
Okay.
So
Well, I mean, that'll be very helpful. I mean, that is very helpful to know that they can be reassessed in the community, and then changes make appropriate.
Correct.
Yeah.
Yes.
Oh, that's really cool. So, this is an interesting part that we've got to. So, for instance, I remember having a patient who thought the social workers were not doing a great job in terms of the patient's needs, right?
Uh-huh.
So the patient came in with a mental health issue. The patient wanted something. The reason for admission is mental health, but the reason for the patient also coming in because they wanted to qualify for a certain government program, right? So that they can receive some financial help. And they have, before they came in, they've spoken to an organization that had told them that they need, let's say, a legal representation to justify why they would need that government program. So the patient wanted the social work to focus on getting them a legal representation. But the social work also think that the patient does not really qualify under that circumstance, but rather they qualify under getting mental health resources in the community for post-discharge care. And this was a friction between what the patient think they needed and what the clinical assessment was on their health. In that sense, like, have you dealt with dilemmas like that where you feel like in the clinical setting the patient meet a certain criteria, but the patient feel they need something else?
Yes.
And how do you negotiate those kind of conversations, right?
Yes. So we do honor the patient's wishes, and we try to work with them. And we do have care conferences. We set up a care conference with the physician, unit manager, case manager, patient, family delegate. And usually we'll try to resolve and try to come up with a realistic goal. So that's the thing. And having inpatient social worker, they actually do not necessarily have the time to apply for the legal stuff, and that's usually done outpatient.
Oh, okay.
And if they do go home, we'll try to get a social work as a home health or outside case manager. For like mental health, there is intensive case management done, like Snohomish County, our county here, they do have intensive case management. And they follow patients usually with dual diagnosis, like mental health and substance use. And they are followed in the community. They actually have many resources they can give them. Like they can help them set up with permanent housing. They used to have some hotel vouchers for patients who are unhoused. So there are those resources. But sometimes, yes, the patient expectation and what the hospital social worker can provide are not aligned. So I think having a clear expectation, and also there are resources we can put on their after visit summaries, how to get legal help, how to get housing, food, transportation. So we screen the patient for their social determinant of health. Every patient is screened. Nursing screen all the patients. Case management doesn't always get to see every patient. But when we see them, we always screen them. Do you have a stable housing, transportation? What are your needs? And now we're even expanding it into going like intimate partner violence, like health literacy. There's many things we're screening patients for. So screening, and once you identify, let's say, patient needs help with utilities, and there are resources you can add to their after visit summary, their discharge instruction. That way, the patient will have at least some resources.
Yeah, I mean, I think you guys are doing a great job. I look at the workload, just like you're saying. Even sometimes it's not every patient that you're able to see just because of the workload, and also maybe
screening them. And see.
Yeah. So working with case managers and social workers in the clinical setting, I think you guys make the work much easier on the nurses because
it's a collaboration.
Yeah, it's a collaboration, right? So and I think that's just, you even mentioned how you guys even collaborate with the financial department of the hospital, which I think is amazing. And sometimes people don't know the amount of work that go into like just one person's care, right? So you only see that maybe the clinical picture and think, oh, they were admitted and discharged from the hospital. But behind the scenes, you guys are there, the financial department, the social workers, and everybody working together, even post-discharge, like you're saying, community resources, partners, supporting in the care coordination, right? So if you ever go to the hospital and then get discharged and you see the nurses coming in and social workers coming in to ask you questions about your health and financial difficulties and your needs at home, please know that it's just to help you coordinate your care when you are discharged. So try to cooperate with them and don't fight with them and go like, why are you asking me so much private questions?
Yes.
Why do you want to know this, right? So know that they care about you, and then the goal of that is to make sure you have all the resources that you need so that when you are discharged, you can be discharged into a good environment that would prevent or decrease readmission, right, into the hospital. Definitely, if you want to be a case manager, you heard Saba telling you have a good foundation, try to work in some leadership position in the hospital that deals with patients and in relation to their discharges as well. So thank you for joining us today. We really appreciate you coming today. Do you have any advice as your last words before we draw these curtains on this?
Once you have been a case manager for like a year or two, I think it's a good idea to get certified because you get more understanding of what the American Case Manager Association, what is their main goal in the transition of care from inpatient hospital it is, and also knowing your resources, understanding where are patient going, what is their goal, and understanding, let's say I will give you an example. Like a patient had a extensive bowel surgery, they can't, they are NPO, but they're ready to go home. They've been on TPN. And have understanding that you understand this patient is going to probably need home infusion. Or let's say patient came with osteomyelitis. Usually we understand that most patients do need 6 weeks of antibiotic. So when you see that diagnosis, understanding and say, okay, this patient had osteomyelitis, anticipating they're going to need 6 weeks of antibiotic. And I will say, furthermore, I said, are they able to do their own home infusion? Is this patient able to do that? And if I say patient is not able to, then I say, what is the next step? Are they going to be able to come here for a daily infusion? That's another option. So you have to kind of separate things. Then you say, if not, they may need to go to like a rehab nursing home to complete those antibiotic. And, to get those, there are things that needs to go through it. You need to know the antibiotic, the cost of it, what kind of line you need for the 6 of antibiotics. So there's a lot to go. That's why it's very helpful. If you have that clinical background, it is a little, you'll be more successful.
So as a case manager.
Yes.
Yeah. And which, when you were saying this, brought me, a last question into my mind about willing participants and non-willing participants. Like, like you're saying, somebody needs antibiotics to go home with.
Yes.
And let's say you feel like the patient is able, they are able to will be able to do their self-infusion. But the patient said, I don't want to do it. And I want like an infusion service, or to do it for me. In that sense, would you still get the infusion service, even if this patient should be able to do, another example, another typical example will be patients who have like ostomy bags and stuff like that, and you have to do ostomy teaching for them to take care of themselves.
Yes.
And some people are like not willing to learn how to do it.
Yeah.
So those people, like, how do we handle them?
Well, I mean, it's the intent. So when you go with the patient, always look at their learning needs and explore what is their apprehension. So what is going on? And also ask, who is there, able, willing, available to help.
Okay.
So those are the questions I usually ask. And if the patient is not performing like let's say the IV antibiotic, there is no per se an IV infusion will come to the home. The responsibility lays on the patient. And if we understand the patient is not able to do it or unable, so we do explore other resources.
Okay.
Are they able to come to the infusion center? Is antibiotic able to be given once a day? I mean, if it's 4 times a day, if it's continuous, they may need to explore going to a rehab place.
To get a continuous before they go home. Yeah, that's a good point.
But the infusion companies, they do come to the hospital to do the teaching, and it's not as difficult. It's easy. It's like a little grenade or a little pump. So they teach them. But with the ostomy, yes, it's a body image change, right? So most patients, they could be apprehensive. But it's just you meet them and you advocate for them and you explain, what needs to happen. And as long as they understand your intent is not to just push them out of the hospital, and that you have the resources they need, and post discharge, who they can call, who's there for them. So I think most of them will be comfortable to do it.
Yeah. Anyways, if you've been with us to this point, thank you very much for being with us. You had Saba here with us with this amazing depth of knowledge and resource and experience right here with us, who have told us all about what case management and their role in care coordination. We really, really appreciate you for coming to share that knowledge with us. The other thing that I want you guys to know is that if you have questions, please put them in the comments. You can always share and subscribe to this channel. Thank you for joining us once again. I am your host, David, and I'll see you in the next episode. And this is the DKA channel.